My name is Bill Peppard. I am your moderator today. This afternoon, our speakers will provide a presentation entitled, What Happened to You? Trauma-Informed Care for the Pharmacy Professional. This session is full of valuable information to help your patients live their best lives. Let's meet the speakers. And as a reminder, all continuing education credits should be claimed through the app, and attendees will be required to complete a brief quiz before claiming that credit. Remember to claim your CE as soon as possible, as the window to collect CE closes after 60 days. First up, Dr. Haley Pels is the Substance Use Disorder Program Director and Psychiatric Clinical Pharmacy Practitioner at the Toma Veterans Administration Medical Center in Toma, Wisconsin. She completed her PGY1 residency through the University of Minnesota's Ambulatory Care Program and her PGY2 at the William S. Middleton VA in Madison, Wisconsin. Dr. Pels performed comprehensive medication management for veterans in the Specialty Addiction Clinic, primary care, urgent care, and inpatient locations. Her scope of practice allows for prescriptive authority for mental health and substance use disorder medications, including controlled substances. She's on the Trauma-Informed Care Committee and coordinates quarterly training for employees to become champions of trauma-informed care principles in their respective work areas. Next up, Dr. Mollie Shoyer is a pain clinical pharmacist practitioner and the PGY1 residency program coordinator at the Toma VA Medical Center. She received her doctorate of pharmacy degree from South Dakota State University College of Pharmacy in 2016 and completed a PGY1 pharmacy practice residency in 2017, followed by PGY2 AmCare practice residency with a focus in pain management in 2018 at the William S. Middleton VA in Madison, Wisconsin. She has been building her chronic pain practice at the Toma VA since 2018 and has expanded the clinical care she provides to include prescriptive authority of controlled substances, including buprenorphine for pain when appropriate, since obtaining her DEA license in 2021. Dr. Shoyer is on the facility's pain committee and suicide postvenation team and is a trauma-informed care champion. She's also trained and credentialed to provide battlefield acupuncture and provides this service to veterans through the Toma VA Whole Health Program. And lastly, Dr. Johanna Katroscik is an outpatient pharmacy supervisor and on the team at the Toma VA Medical Center. Johanna graduated from the University of Minnesota College of Pharmacy in 2021. After graduation, she completed her residency training with the American Pharmacists Association, APHA, in Washington, D.C. Her residency specialized in developing ACP-accredited CE for pharmacists, developing web content for APHA, writing articles in Pharmacy Today magazine, and being part of the editorial team for Pharmacy Today. Dr. Katroscik considers herself a non-traditional pharmacist because she has a liberal arts degree in music and pursued a career in music prior to going back to school for pharmacy. She's been the outpatient pharmacy supervisor at the Toma VA since July of 2022 and is a member of the Pharmacy and Therapeutics Committee, the VISN 12 Outpatient Pharmacy Steering Committee, and the Patient Experience Steering Committee. Additionally, she continues to be an active member of APHA and is member of the Editorial Advisory Board for Pharmacy Today. You can access the full bios for all speakers via the PSW app. Please help me welcome our speakers.
All right. So welcome. Thank you so much, Bill, for that very nice introduction. So we'll skip through some of these slides. As he said, what happened to you? Trauma-informed care for the pharmacy profession. None of us have any relevant financial disclosures. We'll not be discussing the use of off-label meds, and we do not represent the federal government when we're giving this presentation, just ourselves. Learning objectives. All right, and then as has been done in several other presentations, first disclaimer of our presentation is that we are not experts in trauma-informed care. We are all just very passionate about providing good care to our patients, to our coworkers, to other people in our facility, and to ourselves. Yep. Did I skip a slide? Okay. All right. So we're going to start with a little role playing to kind of set the stage for, just to set the stage. So I'm going to be the disgruntled pharmacist, Molly is going to be the lovely pharmacy student, and Haley is going to be a patient's wife.
Picture this in your head if you're going to we'll meet our student later, but I'll let our pharmacist kick it off.
All right, so it's Friday. It's my final shift at the pharmacy before the weekend. My feet are tired from standing 10 hours straight all week. I've been working so much more since my boss left the company and my seniority earned me the temporary role of pharmacist in charge. Man, I loved that boss. Things just aren't the same.
My husband just finished his last radiation treatment and his pain has gotten a little worse because of it. The doctor suggested an increase in his fentanyl patch. I'll have to go to the pharmacy to pick it up since he's too sick to leave the house himself. 25 years with this man has been a blessing. It's so hard to see him in pain, not acting like himself. I hope it's over soon.
As I get in my car and start driving to work, I realize I forgot my lunch at home. At least I remembered the coffee. It's okay. I probably wasn't going to get much time for lunch anyway. I hope my favorite student's working. He always makes the day go quicker and how helpful he is. I already see 5 people in line as I'm opening the gate, and in fact, the new P1 is here. She has so much to learn.
I got here before they still fifth in line. They haven't gotten his new prescription yet. They say there's 40 out orders in the queue from overnight. The new pharmacy student does not understand why I need a fill of this fentanyl patch for today, since I just picked up a month's worth last week. I hate having to explain how bad the pain is. They probably don't believe me since my husband isn't here. Let me ask for my favorite pharmacist to avoid the new girl's judgment.
Why can't the student take care of the new prescription? Oh, God, they increased the fentanyl patch again. What do they do with all the extras at home? I hope they bring them in to dispose them. I've never even seen her husband. Is he real? They better have naloxone still. Oh no, the insurance won't cover it today. I'll have to call for an override. That's going to take forever. The student doesn't even know how to do that yet.
What do you mean they will pay for it? I'm not early. The doctor changed the dose. Why does this happen every time? The longer I have to wait, the longer my husband suffers at home. Call them now.
Why does she need this so badly? They have plenty at home. She can just wait.
It's been over an hour. My husband is asking where I am and if he can take an extra oxycodone for his pain.
Sure, more drugs. I'll teach the student how to call the insurance company after this granola bar.
I feel so hopeless. Great, now I'm crying. I wonder if my husband will ever get relief.
Jeez, what is her problem? We all hate insurance companies, lady. Crying is not going to help.
I don't know where this anger is coming from, but I'm going to start screaming. This pharmacy student needs to call the insurance now.
Oh, great. Now she's yelling at my student. People get so upset about their opioids. That's it. I'm done with this place. Okay, so just to set the stage. So first we kind of want to talk a little bit about what trauma is. So on this slide, kind of the most important take-home piece is that traumatic events disrupt a sense of control, of connection, and of meaning. The American Psychological Association defines trauma as any disturbing experience that results in significant fear, helplessness, dissociation, confusion, or other disruptive feelings intense enough to have long-lasting negative effect on a person's attitudes, behavior, and other aspects of functioning. Traumatic events. Traumatic events can be defined by many different things, and they're usually external to something that's happening to us. So they can be inflicted upon us by either human behavior. So the examples up here, rape, war, physical or emotional violence. They can also happen from nature. So earthquakes, forest fires, pandemics. Who experiences trauma? So as we discussed, trauma can happen to anybody. It can happen at any time. We may not be ready for it, but it can happen to anybody, any human. So when we think about trauma, we think about that big T versus the little t, or what we're going to call big T versus little t. So big T is something huge that might affect you really quickly. So I have kind of 2 different photos up here. So that big T being the one on my right, your left. So maybe some sort of huge disaster, war, rape. Little T might be like small like microaggressions, maybe emotional abuse that are kind of like small and cloying, but not that kind of overwhelming sense of immediate need to take action. We also have the 3 E's of trauma. So we have events, experience, and effects. So events are obviously the things that occur. It could be a one-time massive event, or it could be lots of small events that occur over time that kind of add up and pile on and create that trauma. The experience is what actually happened. And then the effects are those like emotional, psychological, or social consequences that happen. So similar to the best kind of way to describe it is similar to like medication. There's the dose and the duration. So a small thing that happens once might not be something that would affect you forever. Whereas a major thing that happens once might be with you forever, or something small like a daily abuse or a daily microaggression that happens over time can kind of add up. And the other main point of this is that everybody here, depending on their background and where they're from and the different experiences they have, might have a different reaction to the same traumatic event. So something that might be very traumatic to me might have no effect on Mollie. So that's kind of important too, just as you're sort of setting the lens for today. So Haley's going to transition into some of the things that kind of lead up to this.
And I see a lot of familiar faces from the last session. So this is where I get to kind of tie in a bunch of things that we're learning at the same time. But who has heard of the ACEs study? I would say like a dozen hands. I need more than that because I think this is a study that all pharmacists should learn about. This is a study that Kaiser Permanente led in the 90s. And I have a feeling that some people at this conference weren't even alive at the 90s yet. So this information has been around a while. But they wanted to find out why some of their patients in their weight loss clinic, once they lost that weight, why they were gaining it back. Why couldn't they keep that weight off? And so they sent out this big survey to all of their patients who were using their services in the Kaiser Permanente system. And they found that there was a very large prevalence of these ACEs. So things from childhood as, commonplace as divorce, unfortunately, is very common these days, all the way to things like having your parent or your parental figure incarcerated or using substances or being physically or emotionally abused as a child. They're very common. And this study was done in a population of employed middle class people out west. You could imagine that these ACEs are even more common if we were to include different demographics or more areas of of America. So they found that these were unfortunately common, but also the more ACEs that they had, the worse their health outcomes were. So not just the more they drank or the more they used substances or the more depression they had, but also things like cancer, COPD, even broken bones. They found that the more ACEs you had, the more broken bones that you are at risk for. And they concluded that those patients that were struggling with weight loss or with keeping that weight off had more ACEs. And they kind of suspected that maybe eating was a coping mechanism or a reaction to some of that trauma in childhood as a way to escape. And so it's just something that they never unlearned, that they were eating to kind of fill that void or feel better. And so the Dr. Vince Folletti, who was the internist that led this study, ultimately concluded, then might heroin be the best resource that someone has at their disposal to numb a lot of emotional anguish from childhood trauma? And so this was an internist that had this, big epiphany for addiction. And of course, working in an addiction clinic, I love that. He went from obesity to addiction. But this is something that doesn't just apply to me in my clinic or you in your obesity clinics. This is something that can apply to a lot of different places.
All right. So with a little audience participation, wanting to kind of get you guys thinking, how often do you consider or conceptualize the implications of trauma when you work with patients in your care? And if you feel able and willing, I'd love a show of hands. Anyone want to say maybe never, or maybe not never before this talk? How about rarely? Sometimes? Often? Or always? So we have pretty much no one says never or always. You guys probably more fell in that sometimes or often range for those of you that are in the front and can't see everybody. So hopefully, I'm glad to see that no one said never, and hopefully this presentation or this, discussion will help you spur thoughts on making that more towards the often and always actually time frame. So when you think about, Haley and Johanna did a really good job about kind of defining what is trauma, who can experience trauma, what does trauma do to us and look like in our everyday life. Um, this talk is actually more about what is trauma-informed care, right? So we already gave you the background about kind of setting the stage, but now what do we do with that? So from here on out, we're going to talk about some tangible ways and how we can apply this in the work that we do every day. So to define trauma-informed care, SAMHSA has given us 6 principles listed here that help us to do that. So these principles to define what trauma-informed care looks like, we'll touch on, as we go forward, but they include safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. These were really developed by national experts, which included trauma survivors, and they wanted to establish really that common language and framework for what good trauma-informed care could be. And they're really values-based. You can probably tell that by what's listed here. What this principles are looking at is really to help realize that trauma and the impact of trauma is very widespread, right? We already covered that. And to really understand the potential path for recovery, because you can move towards recovery in this framework. Recognizing the signs and symptoms of trauma in our patients, our clients, our families, our staff, others, and maybe even ourselves. The trauma, after becoming a trauma-informed care champion and learning more about it, this applies in everything that I do, from the minute I wake up in the morning to the minute I go to bed, the person I meet at the coffee shop, and the people I'm going to interact with when I go on a flight, right? It's everything in between. And lastly, not lastly, I gotta move this arrow down. Responding by fully integrating this into our trauma policies, and then really thinking about how can we resist re-traumatization, right? So, obviously we know that trauma can affect us in many ways, and unfortunately, we may inflict trauma on people without even knowing it. But being aware of trauma and its impacts and trauma-informed care can really help us resist that re-traumatization on people as well. Really, when I think about trauma-informed care, we use the biohazard sign here because we think about it kind of as a universal precaution sort of practice, right? You can just really assume that every patient may have some history of prior trauma, and to really treat all patients as if they probably have that history. The bottom bullet point is probably the biggest thing here, is that patients disclosing trauma or trauma history to you is not the goal. We don't want to go into care, wanting someone to tell us about their trauma. And in fact, a lot of us probably aren't looking for that. We don't want to have to hear about that. It's the reality that people experience this, but it's not always comfortable or exciting to hear about, right? But if we do get that disclosure, it's actually a gift and a good thing. Hopefully actually giving us feedback to say that maybe we are providing a safe environment that they feel they can disclose this to us, which might share to us that we are providing some of that good trauma-informed care. When we think about trauma-informed care compared to maybe kind of our typical previous medical model, really when there's a couple of different distinctions. On the left side, that would be looking more at the medical model, and you can see kind of the checkbox, right? It's pretty black and white thinking, either or, logical process, kind of that top down, is a lot of the times reactionary to kind of what's happening, and really thinking that healing comes from external things, right? How can we fix you? How are you broken? How can we fix you? When we think about trauma-informed care, it's really kind of the opposite, right? That looks more at, all of the puzzle pieces and how they fit together, like the picture shows, but how can we help you heal, right? Really, what happened to you, right? And how can we help you heal from that? This is more of that bottom-up integrative approach and trying to be more proactive instead of reactive. All right, I think this is on to you.
So unfortunately, we want to get away from the medical model, but we do need to understand the medical model to understand why trauma-informed care kind of makes sense. And so here's where we all all sit on a daily basis as you're sitting in this room. There's nothing attacking you. You feel safe. But say a danger presents. You are in the woods and you see a bear. Your body is going to start going through some chemical reactions, adrenaline, things that will help you choose to either freeze, flight, or fight. Sorry, if you're the bear, I probably don't think you go fight it, but your body's going to start pumping in those hormones like adrenaline, because your body wants you to run now, digest food later, because that's not really helpful for you right now. You need to get going and you need to figure out what to do. And eventually we get back to homeostasis. However, if you get stuck in this mode where you never really go back to homeostasis, you go straight back into danger. For example, if you live in the woods and there's always bears around and you always have to be worried for your safety, or what happens if that bear comes home with you and as you're going home for the night, the danger is underneath your own roof. These things can kind of break this system and not allow our bodies to go back to homeostasis. But especially for children whose systems are still developing, they never learn that it's normal to go back to homeostasis and to calm the body back down. So we get stuck in this loop of constantly feeling like we're in danger and feeling like we need to fight or flight. And unfortunately, when you're stuck in that way, you tend to find some creative ways to maybe try to get yourself out of that. And those creative ways can unfortunately look like symptoms. And so on this right-hand column, there are a lot of symptoms that our medical model tends to use. Who has seen these symptoms in the chart or used these terms yourself? So if we think about our body's natural reaction to want to calm itself down and use other coping skills, we're adapting, but then our medical system is calling them symptoms. So if you think about someone who is unmotivated, I can't imagine how hard it must be to be so overwhelmed that you don't know what to do. It's not that you're unmotivated, it's that you're stuck, you're frozen. And for someone who is maybe non-compliant with their treatment, well, maybe they just want to take that power. You know, we define trauma as losing that power, that sense of autonomy. That's the only way they can keep it, is by being non-compliant or not choosing to go forward with the treatment plan that someone else decided for them. And so this is just how they learn to cope, but it doesn't mean that they have to stay using those coping skills. We can help them by helping them understand those differences and understand what's going on and why they chose to use those coping skills. For example, eating processed foods or seeking out those types of calming strategies. Maybe they're not the healthiest choice, and so let's find some other healthy choices. But we can also help them recognize it by just using better language and by communicating things a little bit differently. Again, taking away that blame and that shame and saying, it's okay that you're doing this. You're doing the best that you can. But now let's see if there's other options that you would find healthier or better for you. So rather than saying, what's your diagnosis? What are your symptoms? Ask you, what's going on with you? What brings you in? How have you been able to cope through all that you've been through? And rather than what's wrong with you, ultimately the question we're here to ask today is, what happened to you? How did we get here? And I'll let Mollie show how this can look in a real case scenario.
Yeah, so kind of trying to think about what we've already talked about and putting it into a scenario. So this is a fictitious patient, by no means anything to kind of say that it's a real person, but we tried to put some of this framework together. So if we think about Amanda, when you look at her or she presents to your clinic, things that are put in her chart and that you kind of first start to see listed are that she has diffuse chronic pain following a spinal surgery. She has some muscle stiffness with movement, feels very fatigued, is been labeled a high utilizer. She's frequently coming to the clinic or to the emergency room, urgent care. A lot of other providers have labeled that she has refused antidepressant medications due to a lot of side effects in the past. She's pretty suspicious of recommendations. You offer something to her and she kind of not really sure that's for her, or she's interested in that. Pretty frustrated with healthcare, has been labeled with a functional neurologic disorder diagnosis and is pretty distressed by ongoing functional decline, lack of clear diagnosis, or maybe just adequate treatment. Anybody starting to think of someone you might know, patients you've seen? When you get to know Amanda a little bit more, you start to see that she does have some baseline ACEs. So in the past, she's had sexual assault, but hasn't been believed. Her father died at a young age, and she's also been a victim of emotional and physical neglect. She has a pretty significant index trauma. She has a spinal cord injury history in the past, had some septic shock following some surgery, and was coerced into some military sexual trauma as well. In addition to those big T traumas, as we labeled before, maybe some little T traumas she's had are things like being forced into having surgery in the past, feeling abandoned or being abandoned as a newborn, medical stigma, just based on some of the things that we presented before, and having some identity-based discrimination. So if we had all of this information prior to looking at the previous information that was given to you, how maybe would that impact your perceptions of her and the care you provide? Do you actually need to know these things, to provide good patient care to Amanda? These would be some questions for us to continue to think about. If we think about really what we first saw in kind of some of the initial things that you started to read into her chart, the way she was presented to you, and then coming to find out more, or maybe not knowing any of that additional information, if we think about this situation, I think a lot of us probably can agree. At first, it seems like this pain and distress almost seems kind of excessive, like she's just overwhelmed. And really, what's the reason? What's the etiology? There's no clear one there. Our usual response would be to say, it's all somatic. She needs to go to mental health care. It's probably all that problem. Figure that out there, right? Why is she in my pain clinic? This is me in my role, right? Why is she seeing me? But maybe our trauma-informed response would be to think about pain and trauma are really connected, as we've already discussed. And having a traumatic past doesn't necessarily mean that her pain isn't real, right? So trying to reframe how our initial gut reactions might be to some of the patients that we see in a typical day-to-day basis, and how we can make that in more of a trauma-informed lens. Is trauma-informed care just for patients? Anyone want to take a guess? No, definitely not. So with that,
Okay, so we kind of covered trauma-informed care for patients, but what about us, right? So I'm an outpatient pharmacy supervisor and I work for the VA. So I can assume, not to assume, but I can consider that everybody that I take care of on a daily basis might have been exposed to some sort of trauma. And what does that mean for me or for all of you in the audience who are pharmacists, right? Whether you are working inpatient, retail, outpatient, ambulatory care, it's important to know that we can also experience vicarious trauma. So thinking about that, like thinking about burnout and compassion fatigue. So just a reminder that like it's a real thing. It's normal. This happens to all of us. It's not a sign of weakness or a bad day or personal issues, right? So the person that's yelling at me in the pharmacy, like really reframing that picture to remind myself that maybe they had a lot of things go on outside of work, outside of their control, and I just happen to be the last stop. That doesn't mean that I can't be affected by it or that everyone here can't be affected by it. It's also super important to me. I'm also a supervisor. So I have to also, or I don't have to, I choose to also take this approach with my whole staff and everybody that I interact with on a daily basis. So I oversee about 15 people, and they all come from different backgrounds, different walks of life. They all have their own diversity that they bring to the table. And so really reframing that point of reference and not making snap judgments. That being said, it does have an effect. There is a cost to caring, both for patients as well as for our colleagues. So, all right, so we'll talk a little bit about compassion fatigue. So compassion fatigue is when we really think about ourselves, right? So that phase one is idealistic. So, right, me straight out of residency, yes, I got a new job. I am so stoked about this job. I am a supervisor. I moved from working for the American Pharmacists Association back to patient care because I really wanted to be back with patients. So, I'm gonna work as hard as I can. I'm gonna take the time to get to know every one of my staff members. And then I start to fade into phase two, right? Maybe like now I'm getting a little burnt out. And so thinking about like different mistakes, right? Maybe like if you're working retail, you're checking prescriptions, but maybe you're like not reading the sig all the way, right? Like one of the things I do is I read every sig on every label of every prescription I dispense. So maybe like I'm getting burnt out, I'm tired, the phone is ringing, Haley's coming to me with a problem, Mollie's sending me a Teams message, and I'm just like scanning over the sig, and maybe there's just a typo, right? Nothing huge, but I'm getting a little irritated because I can't quite keep up. Phase 3 is withdrawal, right? So you're just tired all the time. I commute 2 hours every day. I'm so sick of driving and commuting. I'm sick of dealing with my husband and my mom and my dogs. How can I possibly cook another healthy meal? I'm exhausted. And phase 4, I hate it. I hate everything. I hate Haley. I hate Mollie. I hate my patients. I'm just mad all the time, right? Because now instead of filling my cup and taking care of myself and maybe being trauma informed with myself, I've hit that zombie phase. So how do we overcome it? So it happened, right? Healing happens in connection. So maybe I reach out to Mollie and I say, Mollie, man, I'm so mad. I'm so tired. I just need help, or I have my new supervisor pal, and I just send her a Teams message and I say, man, I'm just really burnt out, but we connect over it. And she's like, no, you're doing great. I'm burnt out too. Let's go for a walk. Let's figure it out. So there are ways to kind of overcome this compassion fatigue, even if they're in small micro doses. Haley, pass it back over to you.
I've experienced that zombie phase before. Thankfully, I had a lot of support in our environment. I'm actually going to go back to this slide and just show you that kind of three-pronged approach that helped me in our organization. So I could feel myself approaching that zombie phase, and I knew I was kind of starting to get frustrated and burnt out. And then one day during an appointment with a patient who I prescribed buprenorphine for opioid use disorder, I had found out that his prescription had come late. It didn't arrive in the mail. We didn't mail it out in time. And so he did not get that prescription. And by day 3, without his buprenorphine, he was in a horrible opioid withdrawal, was struggling with how to ask for help, and ended up realizing that, hey, I know what could help my opioid withdrawal: heroin. And he ended up using, and because it had been so long that he had been on the buprenorphine and not used, he overdosed from that one time. And thankfully, his provider is a pharmacist and made sure that he had naloxone at home. But the fact that he overdosed because his prescription didn't come in time, as a pharmacist, I felt a lot of responsibility for, like, we should have done better. What happened? And after I finished that phone call and made sure his treatment plan was back on board, I was furious. I was seeing red. I wanted to fire whoever the hell was in charge for that prescription that day that did not go out. And thankfully, I have supervisor support, that interpersonal piece. She called me out for it. She said, hey, I see this. I understand this is frustrating. I think you should go home. I said, great idea. I went home. I used my personal resiliency strategies, and I coped at home. I spoke to my husband. I hung out with my dogs. I used my own personal coping skills to kind of decompress and step away from that. And I'm glad I did, because I know I didn't want anyone to get fired that day. I know that it's not as easy as that. I love my HRO principles, my high reliability organization of let's figure out the problem, not blame someone for it. But when you're in that zombie phase, or you're so worked up like that, you can't think that way. And so when I came back, that organizational support piece, did a root cause analysis, figured out where those Swiss cheese holes were in our model. And we now actually have an improved system for sending out controlled substance prescriptions to have a buffer, so that our patients, if they are late to get their prescription, they still have some medication to get them for a few days. Because Wisconsin never has snowstorms that stop our mail trucks or UPS strikes that, threaten our prescriptions getting there on time. So all of those steps were put into place to kind of help that situation. And no one got fired. Don't worry. I calmed down. I realized that was not rational, and I moved on. And I learned the importance of being able to use these resiliency strategies more proactively and more frequently to avoid that zombie phase. Because once you get there, it's possible to come back, but hopefully you guys all have supervisors who will tell you to go home before you do something that you regret or get someone mad at you. And so these kind of resiliency strategies I've started using a little bit more often. I have my social support. I make sure that I've got a mentor. I make sure that I always have meaning in my work. I love what I do both at work and outside of work. I have a lot of meaning in what I do. Humor. Who uses humor as a resiliency strategy? I feel like there should be more hands on that. I've worked in a pharmacy before. There's a lot of dark humor going around because if you don't laugh about it, you cry about it. That's what I always hear. And it's just finding ways that work for you and finding work groups and people that cope the same way as you do. Because sometimes I go to a coworker and I just want a 5-minute vent session and they try fixing it and they try helping me. Like, no, just let me complain. I'll be done in 5 minutes and then I'll feel better. So find those people that use the same resiliency strategy or use the same coping. Johanna mentioned going on walks. At one point in time, we're like, yeah, we should go, find each other at work and walk more often. She learned I hate walking and we haven't done that very often. So if you're a walker, find someone who actually wants to walk with you and then you will be able to implement those kind of little steps in your day to take a break from work and step away. But it's not always possible if you find someone who doesn't actually like doing what you want to do. And we can use all of these strategies, but as we're thinking about how we can improve our workplace, we're going to revisit those principles that Mollie was talking about and thinking about, do we have all of these pieces available to us, whether it be for us as employees, our supervisors, making sure our employees have that, or for our patients, are these things all thought about in our processes? So do you have outlets for peer support, or do you work 100% remote and never get to see any of your colleagues? Do employees and patients feel like they have a voice in changes that are being made in your processes or in what you're doing in the pharmacy? And start with looking at those areas that you maybe can't identify or don't think you have present, and use that as a starting point for any changes or improvements that you want to make in your workplace. And don't forget to consider every angle. And I'll explain what I mean a little bit more if we look at safety. So if what we might think makes a patient feel more safe, so giving them that autonomy back, giving them more power in their care, may not always be the same thing that makes the provider feel safer. So what can we do to keep that power? How do we feel safer and mitigate risk? And it doesn't mean that those two things have to always conflict or you can't find compromise, but just make sure that as you're considering all angles that they both are being considered. That both people or both sides of things are happy and are safe in what we're doing. And that goes for every single principle. So in practice, start to question some of your processes, your procedures, logistics, even equipment that you have around the facility. Start questioning, is this trauma informed? Is there something that could be taken wrong by the wrong person who's maybe like we said earlier, we want to resist the urge to re-traumatize. Is there something in the messaging on our new poster that could be changed? And these things may take a little bit longer to change, or they're not going to be fixed overnight. But there are some strategies that we can do. Like you guys can leave here today and start using some of these phrases, or start thinking about the way that you're communicating to your patients a little bit differently. So again, changing that non-compliant piece. They're not compliant with their medications. Well, no, maybe they're non-adherent. And when we phrase it differently, non-adherence, because of what? It kind of begs that question of why aren't they adherent to their meds? What's going on that I could make this easier for them? I had a patient who said, well, those pills are too big. I just literally can't swallow them. All right, it comes in liquid. Do you want that? Yeah, that sounds good. They were non-compliant. It's that they were non-adherent because they physically could not swallow that pill. And then this is my favorite one. In my line of work, when I ask people about their substance use all day long, it's not that they admitted to substance use, it's that they described this is their current use. And substance use or whatever the situation might be, I think we should get rid of that. Patient admits to doing this because it's not something that they should have to lie about. It's not your husband eating that last Girl Scout cookie, even though he told you he didn't. This is patient care. They're supposed to trust you with what they're saying, and we're not supposed to judge them for what they're doing. We're supposed to respond to that and provide care no matter what. So Mollie, can you show us how this can look for Amanda?
Yeah, so if we go back to our patient case, you remember Amanda from a while back. We remember that she was that pretty challenging quote patient, right? High utilizer, pretty complex, and really no known etiology, so to speak, like why is she presenting this way? Really at the bottom of the slide here kind of highlights where we're trying to get at, right? Our thoughts really lead into our feelings, which then leads into our behaviors. So instead of really thinking of Amanda as that challenging patient with the history of and claims to be interested in getting better, but she's non-compliant with the stuff we tell her to do. She comes here to these appointments and we recommend these things and then doesn't follow through, no shows the appointment, or doesn't end up getting scheduled for the appointment. We list a whole bunch of medications she could try, but she's not interested in any of them. She's combated when we try to refer her to mental health because we said, you know, geez, it seems like you have a lot going on. I really think you would benefit from seeing a mental health provider. And she just gets really upset that we even suggested that. Maybe we want to think about Amanda in this light. So when we're thinking about documenting or even just our mind frame, when we see a patient like Amanda, trying to view her as someone who's maybe unsettled in a chaotic and overstimulating environment. Would she benefit from waiting in maybe a more quiet place? You know, was the TV blaring? Did she have a whole bunch of people behind the scheduling desk talking about a bunch of things that she couldn't understand and then trying to listen to, you know, check in, but couldn't understand things because so many other people were talking, different scenarios there. When you review her previous record, you could maybe list it as, you know, her previous record suggests that she has had a lot of difficulty with certain medications, including SNRIs. She has a lot of unwelcome side effects instead of patient refuses medications. Maybe she's worried about concerns about her pain not being taken seriously. And maybe that's why she is not excited about this referral to mental health. Oh, great. You're another person who thinks it's all in my head, right? We hear that a lot. And instead of saying that she's, you know, failed treatment opportunities or treatments, right, has tried physical therapy several times with minimal benefit. One of the things I think about here is there's a lot of context to what that treatment looked like or where they were at in the stage of their life or where they were even at mentally and physically themselves and maybe their whole trauma process, right, to be open and ready to accept something. So again, if we view Amanda in this light, our thoughts about this patient really portrays into our feelings, which then portray into our behaviors, even in the way that we interact with this person in our own clinic setting, you know, when we see them in our appointment, but also how we interact with them and other people, like our colleagues, right, and other people in our clinic. You know, it's not me calling up Johanna and saying, yeah, it's this high utilizer again. Here he is for another fill of whatever, but thinking about this person as an actual patient who has a history as well. If we go back to the pharmacy, our original setting the stage, he'll now get to meet the student. So I'll let you. Thank you. Oh, I'm first. Okay. Yeah, sorry. I have multiple pages here. Okay. Sorry, we got our sheets all mixed up. All right, so I'm the student. I'm the one in the middle. You can't see. I look pretty upset, but anyways. All right, so I've held out long enough. I finally decided to get a job at the chain store. I didn't want to go up into retail pharmacy, but admittedly, it does pay better than the coffee shop. And I probably should save up some money if I'm going to do 2 years of residency for a psychiatric pharmacy. It's my 3rd week. The boss that hired me just left, but at least I really look up to the temporary replacement. I can
Try this one. It's Friday. Does that work? Okay. It's Friday. It's my final shift at the pharmacy before the weekend. My feet are tired from standing 10 hours straight all week. I've been working so much more since my boss left the company, and my seniority earned me the temporary role of pharmacist in charge. Man, I really loved that boss. Things aren't the same.
And again, my husband just finished his last radiation treatment. His pain's gotten a little worse. The doctor suggested an increase of his fentanyl patch. I'll have to go to the pharmacy to pick it up.
I get in my car. I start driving to work. I realize I forgot lunch at home. At least I remember the coffee. It's okay. I probably wasn't going to get much time for lunch anyway.
Thank goodness for the leftover free coffee from the shop. I'm ready to work, and hey, look, it's my favorite pharmacist opening with me. Hope I can impress her today.
I've had to before they open, but I'm still 5th in line.
I'm proud I remembered how to search the queue for new pending prescriptions. This seems like a high dose of fentanyl to add into this last week's fill, but maybe they're increasing it. It looks like the dose my dad was on at one point. Maybe I should check if they have naloxone at home, just in case.
Why can't the student take care of this new prescription? Ugh, they increased the fentanyl patch again.
So it's not an early fill. It seems like they want a completely new strength. Seems reasonable. I should try calling now to her for help.
What do you mean they won't pay for it? I'm not early. The doctor changed the dose.
Why does she need this so badly?
I'm new here and I already don't like insurance companies. I feel bad because she's had to deal with this. I hope her husband's feeling okay at home.
It's been over an hour. My husband is asking where I am. Can you take an extra oxycodone before I get home?
Sure, more drugs.
He probably should increase his short-acting opioid while he waits. Oh, good. I get to call the insurance company now to help. Yay, learning.
I'm hopeless and great. Now I'm crying. I wonder if my husband will ever get relief.
Jeez, what is her problem? We all hate insurance companies, lady. Crying's not gonna help.
Ugh, I can't imagine how hard it must be to help your husband in pain. They must really love each other.
I don't know where this anger is coming from, but I'm gonna start screaming. You need to call the pharmacy call the insurance company now.
Oh man, I really wasn't expecting her to get angry. This must be really frustrating. It looks like he's been getting these pain medications for 10 months. That's a really long time to be dealing with cancer treatment. I hope it's almost over and he gets better, or maybe it's not going well and that's why she's so upset. I wonder what he's like.
Oh, now she's yelling at my student?
I'm sorry that your husband and you are going through something so painful for you both. Would you like to wait privately in our immunization room while I try calling the insurance? No promises, but I hope that you can come back to him soon to see if the new dose helps.
I guess I never realized how much I had gone through myself while caring for him this past year. It's been rough. I don't have time to eat much, and I certainly haven't done my hair and makeup in ages. I was so hoping this would be the last prescription of opioids before we could start weaning off. I don't want people to see me cry like this. Privacy would be nice. I should apologize to this poor kid. 6 months of ATAC. I have to pick up the last prescription of short-acting opioids for my husband's taper plan. We just found out today that the treatments worked and he's cancer-free. His pain is so much better. Coming off the opioids has been hard, but not nearly as bad as treatment. I hope that student is there today so I can share the good news.
I see a new prescription come through for her husband's opioids. She's been so excited to get him better. This looks like it might be the final step. I hope I'm here when she comes to pick them up. I still haven't met him. I wonder what he's like.
Oh shoot, the student is on a lunch break. I don't fill other prescriptions here, so I probably won't see her again. I don't plan on picking up any more opioids after this. Maybe we'll stop and get a bottle of champagne after this to celebrate our new healthy life.
You know, before I go home, I should pick up a bottle of wine for friends' Thanksgiving party. Oh my gosh, is that her? Should I say hi to patients outside of work? I was so excited to see her today. I'll just wait and see if she recognizes me in my sweatpants.
Oh my God, husband, that's her. There she is.
Is that her husband? Oh man, he looks so healthy and they look so happy. Holy cow, he's cancer free, almost done with opioids, celebrating with a Euro trip. Man, how far they've come since I started.
I'm the husband now. Thank you so much for taking care of my wife when I couldn't.
So hopefully from the beginning to, the reimagined scenario, we all can kind of take bits and pieces of some of the trauma-informed care thoughts and principles and, things we spurred, hopefully, to think about. Everyone has another layer under their story, right? Including the pharmacist, the student, the patient, or the patient's wife.
All right, so to take it home, these are some of the key takeaways that we're hoping that you'll take home. So giving a little bit of safety to patients and to yourselves and to your coworkers. Remembering that fundamental question of not what's wrong with you, but what happened to you? How did you get here? Remembering that symptoms are adaptations to traumatic events. So not necessarily that they're non-compliant, but something might have happened that they maybe are non-adherent. Healing happens in relationships. So find those connections wherever you work and build on them. build on success and not deficits. This is probably my favorite one. So, you know, it's small steps. It doesn't have to be, you know, you don't have to climb the stairs, but like one step at a time is pretty awesome. Kind of like in the last presentation about food, like, you know, maybe just not eating like a bag of chips once a month might be helpful. And then prevention is far more impactful. This is a slide that we added. We're not going to read through it because nobody wants to hear that. But this is a slide that we added so that all of you can access it later and use it at your will. So use it however it might work for you in whatever setting you work in. Same thing with this slide. So kind of just different ideas of what you can do if someone becomes triggered, how to meet them where they are, and maybe take that step back, take a pause, take a breath, and meet them where they're at. So this is just a tool slide for you all. Same with this slide, additional resources. If this spoke to you or if it just kind of piqued your interest, these are just different resources that you can take a peek at, different books, different websites. And then our learning assessment questions. We won't go through them.
Save more time for questions, but also resources. If you're in the VA and want to learn how to become a trauma-informed care champion, please see me after.
Yeah. So with that, we'll open it up for questions if there are any.
I know we have lots of time for questions, so please speak up. I think there's a mic back there, so we can get it on recording, but also we can just repeat things if you guys shout them out.
Question started for you. What a wonderful topic to address. I'm fascinated by the application of trauma-informed care principles to leadership and overseeing a team and staff or students or residents. Can you comment on how your interest in this topic has shaped how you approach your leadership style?
Okay, I guess that's yeah, I guess that's right. Yeah, so Haley was generous enough to invite me to the trauma-informed care like training. I wouldn't call it forced. I guess it was a little over a year ago now. For me, it works in a couple different ways. So one of the ways that I utilize it is I do have staff members sometimes who do go very quickly to blame or to judge. So one of the ways that I use it is to kind of open a conversation or a dialogue with those staff members who might be making an assumption about somebody that might be incorrect. So kind of just working through a scenario and maybe talking about different reasons why somebody might be needing a medication early, or if something's lost, kind of just dialing it back. I also, there is the training that we have quarterly. I've opened it up to my staff and I openly encourage any and all of them to attend this training. Those are kind of the main ones that I do. So I kind of have more open dialogue with my staff and then also encourage them to take the training, learn more from the people who are more experts.
And I guess I'm not a supervisor, but I will say, I mean, I'm our residency program coordinator, and I know, a lot of discussions we have in our residency advisory committee, and just in discussions with our learners in general, is thinking about this aspect as well and how trauma-informed care is important even in the learners that we engage with as well. They all come to us with backgrounds as well. Even just the ways that we present, options to them or the types of topics that we discuss, and really, like Johanna said, kind of having open discussions about this, right? Not keeping trauma in, a wastebasket and under the bottom shelf that we don't discuss. Obviously, disclosure is a gift. We're not in it to have everybody sit at a round table and have a therapy session, right? But to really understand that in everything we do, it can impact us and the responses we get and the way that we present and share things as well. So that goes along with that. cost of caring as well, both for ourselves in clinical roles, but also recognizing it in our colleagues and our friends and our staff.
The other side of it, like I shared in my example, I think the way that my supervisors have fostered that acceptance of this concept. I understand that they're all trained in this, they all understand this. Therefore, when I was in that mode and I needed that help and that trauma-informed care lens from my supervisor, I knew that they would understand it. I knew that I could come to them. So just fostering that safety element amongst your staff and those people that you supervise so that they know if they do need that, they can come to you and you will understand it. Again, you're not there to be their therapist and respond to it by fixing the problem, but as their supervisor, you are accommodating of that, or you understand where they're coming from, or you understand that they might need some support in this moment. And I think just being open about that and so that they feel comfortable coming to you in those moments was really, really helpful. Other questions, thoughts? I know the mic is really far away for those of you up front. So do you guys have any questions, or anyone who doesn't want to run to the mic, feel free to shout out.
Shout it out. Yeah, or come up.
There's a lot of individuals in the room that precept students and residents and might have a desire to incorporate this into their training. Many of us are very comfortable incorporating clinical elements into practice, but behavioral elements can be a little more challenging, a little more touchy-feely. What would you say to the preceptor that maybe is a little self-conscious about introducing this topic into rotation to empower them and give them confidence to teach this to the next generation?
That's a really good question. So I just started precepting this year myself. And I actually had my 2 third-year students this year do like create flyers or handouts. So I asked them if they'd ever heard of trauma-informed care. They hadn't. And so I actually just asked them to like look into it and to ask like for help along the way, but to kind of do a little deep dive themselves on their own. I gave them time, but like on their own. And then to present a flyer to me as though it was going to be hung in the outpatient pharmacy, or it could be hung in a retail pharmacy, or it could be hung anywhere, to kind of open it up to people. So that's one way that I've incorporated trying to get students to think about it and talk about some of those soft skill pieces. I don't know if that answers your question or helps, but yeah.
Sorry. We're doing the dance up here. I would say for us, I mean, fortunately, I shouldn't say unfortunately, fortunately for us, as these others have said, we have a program for this that's offered quarterly for people to become champions. We encourage our residents to attend this. So both of our residents are trauma-informed care champions. So kudos to them. It's not a requirement, but we very much, encourage them, and it's offered quarterly. So we encourage them to do that at the beginning of the year. I also think, for me as well, I think we just have to kind of also walk the walk a little bit, right? When we talk about patients, when we talk about our coworkers or our other people that we work with, how do we talk about them and how do we present that? And also being okay to reframe the students' thoughts initially too, or the ways that they document. I noticed that you documented in this way. Have you considered documenting it as this, right? And some of those examples that we shared. And that's a nice way to bring up some of those principles as well. I also have in my elective rotation that I have students take, we do 3 topic discussions, and I added trauma-informed care as one of the options. Obviously, I make my list saying, here's some ideas. You can obviously decide others if you are interested in them, but I'm hoping that's a good way to spur some thoughts. Even if they decide not to do a whole topic discussion on it, maybe they'll look into it a little bit themselves, and that may spur some natural discussion amongst ourselves as well to discuss what that looks like.
I like the way both of you are saying, kind of, instead of I'm going to force this information on you, I want you to look it up and make a judgment for yourself. Because with concepts like this, sometimes as a mental health provider, I always feel like, well, people are always going to think that trauma-informed care is only for me. It's only for the mental health patients, or it's only for the mental health providers. And that's just not accurate at all. It's definitely for all of us. But people hear that and sometimes they kind of shut off. So I really like the thought of having the learners kind of look at it for themselves and make their own judgment, and not giving them too much hint or information, so that they can see that, oh yeah, this is, a concept for everyone, not just The mental health preceptor that makes me leave at 4:01 every single day. I think it's natural for me to do it in my practice, in our rotation. I do those kinds of things of, hey, you're not staying late, you're going home. If you have things left over, I will take them over because I'm your preceptor and that's my job. Hey, it's match day. Okay, I'll see you on Thursday because you don't want to be here on match day. That's stressful. We after every suicidal patient check in. How are you feeling after that? I feel like it's very easy for me to work the trauma-informed care concept throughout, but for other practice settings, I really like having it as like a standalone self-learning so that they can decide what questions they want to ask. But again, that practice what you preach thing helps a lot too, just demonstrating these. And now you guys all know about them. You can do that. We will be up here. I think we're at time, but if you guys have any more questions, we'll stick around for a little bit. Thank you. Thank you.
And I'm guessing you want the CE code especially, so there's that.